Hello, my name is Alli Tulley, and I will be presenting on community-acquired pneumonia today. So, an overview of community-acquired pneumonia. Pneumonia is an infection in one or both of the lungs. It can infect the parenchyma, the alveolar spaces, and or the interstitial tissue. It can be confined to a lobe, a segment of a lobe, the interstitial tissue, or the alveoli bronchi. Pneumonia can be caused by viral, bacterial, or fungal pathogens, or a combination of pathogens, and fungal is the least common cause. Community-acquired pneumonia is acquired in the community versus in the hospital or residential facility, which would be a healthcare-associated pneumonia or a ventilator-associated pneumonia. The disease severity can range from mild to life-threatening. It affects about 5 to 10 million people in the US annually. It's a sixth leading cause of death. It's also the most common cause of death from an infectious disease. It's the most common cause of sepsis and septic shock, which it accounts for 50% of all episodes. And pneumonia is the number one cause of death among children worldwide. Pneumonia cases, they put a strain on the healthcare system, especially during the winter months. They account for 1.5 million ER visits and 1 million adult hospital admissions yearly. The pathogenesis of community-acquired pneumonia. Pneumonia is caused by an invasion and overgrowth of a pathogen, either viral, bacterial, or fungal. The severity of the disease depends on pathogen factors, including the virulence and inoculum size, as well as host factors, including age, comorbidities, and other risk factors. Once infected, there's an impaired immune response and or dysfunction of the host defense mechanism, allowing for an invasion and overgrowth of the pathogen. Pathogens enter the lower respiratory tract either by inhalation of infectious aerosols, aspiration from oropharyngeal secretions, homogeneous spread from an infected site, or direct extension from an infected foci, and dysbiosis, which is the spread of normal lung flora. This occurs when the normal equilibrium is disrupted. Pneumonia occurs when there's acute inflammation, and typically the lungs become consolidated when the alveoli fill with exudate. When this occurs, gas exchange is impaired. Risk factors of pneumonia include age, especially extremes like very young or very old, other respiratory infections, cigarette smoking, chronic disease, including COPD, diabetes, renal disease, coronary artery disease, and heart failure. Alcoholism, when an individual has a poor cough effort, they're more at risk for pneumonia. When they have GERD, and if they're immunosuppressed. Bacteria causing community-acquired pneumonia include mycoplasma pneumonia, streptococcus pneumonia, which is the most common. Fortunately, these cases are declining with increasing immunization and decreasing smoking rates. Another bacteria is Haemophilus influenza, chlamydia pneumonia, Moraxella catarrhalis, Legionella, Klebsiella, Staphylococcus aureus, and anaerobic bacteria. Anaerobic bacteria is more common with aspiration pneumonia. So, community acquired pneumonia symptoms, there's typical and atypical. So, typical symptoms include sudden onset, fever, cough, a chest pain, which is most is like a pleural type pain, um, fatigue, and myalgia. The typical cough presentation for community acquired pneumonia is productive in nature and is most commonly seen with a bacterial pneumonia. Atypical symptoms, they're more gradual in onset. These patients tend to have a more dry, hacking cough. They have fever and more of a prominence of constitutional symptoms such as like pounding headaches, coryza, sore throat, shaking, chills, and myalgia, along with the typical symptoms. Just an important note of community acquired pneumonia in older individuals, they may not show a fever response like shaking chills, teeth chattering chills, and they may not report pain such as headache and chest pain. But this doesn't mean that their illness is not severe, especially when they're at higher risk of worse outcomes because of their age. So, on physical exam for a patient presenting with community acquired pneumonia, they usually look acutely ill. They exhibit unilateral respiratory splinting. They usually have a cough and it's usually productive. They may have tachypnea, tachycardia. On exam, they may have abnormal breath sounds. So you may hear diminished breath sounds and crackles. They may have dullness on percussion, and they may have egophony, which it makes their E's sound like A's. They may have bronchophony. So when you're listening to their lungs, their voice sounds are louder and clearer than normal. And they may have whispered pectoraculi, which is when their whispered sounds are louder and clearer than normal. With viral pneumonia, these patients tend to, like we just talked about, they tend to present gradually. They have a high dry cough, high fever. They may have shortness of breath and muscle pain. Differential diagnoses. The top three are acute bronchitis, tuberculosis, and lung cancer. So when a patient presents with symptoms that is like community acquired pneumonia, they should be ruled out for these three differentials. So for acute bronchitis, acute bronchitis and pneumonia are respiratory infections, and they both cause high fever and a productive cough. Differing physical exam findings include when a patient has acute bronchitis, they'll have clear lung sounds. They may have a few scattered bronchi and possible tubular sounds, versus when they have community acquired pneumonia, they'll have crackles, abnormal breath sounds, and dullness on percussion. For tuberculosis, these patients also present with pulmonary symptoms along with fever, and they may have weight loss. So just important to have tuberculosis in the back of your mind. And then lung cancer, this is kind of a like high risk differential. So when patients with community acquired pneumonia and when they have a lung cancer, they present with symptoms that mimic each other, including a productive cough, a fever, and dyspnea. Along when somebody has lung cancer, they may have hemoptysis. So, laboratory and diagnostic workup for community acquired pneumonia. The gold standard is a clinical exam and a chest x ray. So, for your chest x ray, you want lateral and anterior posterior views along with the clinical exam. A chest x ray can help distinguish viral versus bacterial. When you see lobar infiltrates in dense homogeneous shadows, that is strongly suggestive of a bacterial pneumonia. When there's interstitial infiltrates, that's suggestive of a viral pathogen. The American Thoracic Society just released a clinical practice guideline, which discusses a soft recommendation to use a lung ultrasound in environments where you may not have access to an x-ray. So they recommend a lung ultrasound in settings where chest x-ray is not available. But the criteria for that is a skilled clinician must be available to read and identify pneumonia on an ultrasound. Another test you may want to run is a complete blood count with differential. So this is really to distinguish if an individual should be admitted. And obviously you would look at this along with the rest of their clinical factors. Obtaining a sputum specimen and performing a gram stain is helpful in patients with severe disease, including those with COPD, end-stage renal disease, patients with illicit substance use, alcoholism, if they have a history of a previous hospitalization, and really the evidence and guidelines say that this is optional for outpatients. These patients you may want to do a respiratory panel on, like an influenza testing. This can rule out or in like a viral respiratory disease. And really any patient that presents with dyspnea, any like shortness of breath, even in the clinic, they should have some pulse ox put on them just to make sure that they're stable. So, what would the plan of care be for somebody that has community acquired pneumonia? So, first of all, looking at prevention, influenza and pneumococcal immunizations, along with the use of childhood vaccines, can help prevent pneumonia and or decrease the severity. Healthy living practices, including hand hygiene, avoiding contact with sick people, cleaning high touch areas, and proper sneezing and coughing techniques can help prevent respiratory illness, including pneumonia. And then smoking cessation. So, when somebody quits smoking, it lowers their risk of pneumonia and severe pneumonia. For non-pharmacological treatment, so it's really going to focus on hydration, rest, and humidified air just to help with the respiratory symptoms, cough, sputum production. And then pharmacological treatment is based on, you want to base it on your suspected pathogen. So you want to take into consideration your clinical assessment, your diagnostic, so your chest x-ray, what does all of that look like, and base your treatment on that, your pharmacological treatment on that. So analgesia for pain, so Tylenol, ibuprofen, depending on your patient, to really help with those constitutional symptoms. So fever, body aches, muscle aches, that sort of thing. And then antibiotics. So the guidelines for patients with no comorbidities, you want to treat them with a monotherapy. So amoxicillin or doxycycline or a macrolide antibiotic. And just to keep in the back of your mind, you should have an awareness of local antibiotic resistance. And you can find that online. Individuals with comorbidities such as chronic heart, lung, liver, renal disease, diabetes, alcoholism, or a malignancy, you want to treat with a combination therapy. So, augmentin or cephalosporin, cephalosporin along with a macrolide or doxycycline, or monotherapy with a respiratory fluoroquinolone. Um, and one of the biggest things you kind of want to think about with your patient, like, do they need to be hospitalized? So, what you would do is you um, would want to look at their if they have a severe community acquired pneumonia. Look at your patient. Can they handle an outpatient treatment plan? Um, and definitely, this should be with shared decision making. So, again, just something, just like a little clinical pearl, the updated American Thoracic Society clinical practice guideline that was just released, they do support treating high risk individuals with comorbidities with a positive viral respiratory test and x-ray evidence of community acquired pneumonia. They do recommend treating those individuals with antibiotics just to account for possible viral or bacterial co-infection. These patients that have the comorbidities, they're at higher risk of severe disease and death. So the new clinical practice guideline does support antibiotics in those cases. And these are my references. Thank you.